Hello, welcome to your online lecture for the course Pathophysiology 1. In today's lecture, we're covering neurologic disorders. And we're going to start with dementia and Alzheimer's disease. Dementia is really a general syndrome that, as stated here, describes the acquired deterioration and progressive failure of many cerebral functions, so having to do with the brain. And it's going to impact features such as memory, intellect, awareness, and language, but the most common, as you can see, is memory, which is impacted with dementia. There are different pathophysiological mechanisms, with really the common denominator being neuronal degeneration. Now, whatever the cause, neurons are lost. They're lost within the gray matter of the cerebral cortex as well as the basal ganglia, and this is going to induce brain atrophy. So we're getting the cells of the brain that are becoming smaller in size. There are certain events that can really accelerate this degeneration and the subsequent dementia, including atherosclerosis, which is a disease of the arteries where plaque or fatty material is deposited within the walls of the arteries. And so if this is evident in the brain, it can accelerate the development of dementia. In addition, brain trauma, so if there's been some sort of injury to the brain, as well as brain tissue compression, there's a variety of different methods by which the brain tissue can be compressed, and we'll be talking about some of those today. On this slide, you can see various different causes of dementia. This is more general here on the left and then more specific here on the right. And you can see that some of them are potentially reversible, whereas others are considered to be irreversible. Now, with the potentially reversible causes, these are things that look like dementia, and that's why before diagnosing somebody with, for example, Alzheimer's disease, you need to look at the different causes, what may be causing their dementia. Just because they're having issues with memory or awareness or language, it doesn't necessarily mean that they have Alzheimer's disease. It could be one of many different things. So then individuals that have the clinical manifestations of dementia should be evaluated with laboratory tests, with neuropsychological testing to identify the underlying conditions that could possibly be treatable, potentially, especially with the potentially reversible causes. And though it's important to know that there's no specific cure that exists for most of the more progressive types of dementia. Now, the most common causes of dementia, which I'll highlight here, are induced by alcohol, Alzheimer's disease, as well as vascular dementia. Creutzfeldt-Jacobs disease, you may have heard of this as mad cow disease, and you can see many other different potential causes. It's important to know that dementia is not only Alzheimer's, because oftentimes people assume that if somebody has dementia, then it means that they have Alzheimer's disease. The two terms should not be used interchangeably. So somebody with dementia does not necessarily then have Alzheimer's disease, but somebody with Alzheimer's disease has a form of dementia. So think of dementia as being really an umbrella term for many different conditions that involve such characteristics as loss of memory, and of course, changes in intellect, awareness, language, etc. But of course, memory being the most common. Alzheimer's disease is an important type of dementia to discuss, not only because it's the leading cause of progressive dementia, but also because it's quite common in Canada. And with Alzheimer's, the brain typically shows areas with what are called neuritic plaques, which are really dead neurons. There'll be deposits of what is called amyloid protein or beta amyloid protein. We'll see this a little bit later. Neurofibrillary tangles are seen as well, which are really intertwined tangles, but I'll come back to that in a moment, or intertwined axons. And then, of course, neuronal degeneration. Alzheimer's doesn't affect the entire brain, but more so just specific areas of it, and it can affect different people differently. And the syndrome usually consists of memory loss, confusion, and disorientation, as well as difficulty concentrating. Now, just to go back to the neuritic plaques and the neurofibrillary tangles for a moment, the term tau protein we'll see that as well on an upcoming slide, is a microtubule binding protein. And in neurons, it can detach and it can form an insoluble filament that's called a neurofibrillary tangle. So this term here. And this can contribute to neuronal death. And so these neuritic plaques, the neurofibrillary tangles, these amyloid protein deposits are more concentrated within the cerebral cortex as well as the hippocampus. And the hippocampus is really big in terms of its importance in memory. Looking at this image on the left of the screen here, the longer arrow that you can see here is showing you what the beta amyloid protein deposits look like that end up forming these plaques. And then the smaller arrows are showing you the neurofibrillary tangles. Now let's compare the normal healthy brain to that of somebody with advanced Alzheimer's. You can see differences immediately looking at a healthy brain compared to that of Alzheimer's. With Alzheimer's, you can see it's a lot smaller. There is loss of neurons. The gray matter is thinned, which you can see all throughout here. And so the cerebral cortex and the basal ganglia are smaller. This region here, the hippocampus, is also smaller. That's involved in memory. And the ventricles will appear to be enlarged because of the shrinking of the material around it. There is substantially more white matter than there is gray matter. You know, when you compare here. And the sulci, and it's very clear in this image, are much wider, much deeper. The gyri are a lot thinner. And this would be more evident in the frontal and the temporal lobes than other areas of the body. So you can see here areas of language and areas of memory would be impacted in those with Alzheimer's. And you can see why that is, how this area has thinned quite a lot when you compare it to the normal healthy brain. So let's look at the proposed risk factors and pathogenesis of Alzheimer's disease. There are two types of Alzheimer's disease. Familial, or early onset, and this is only about 10%. Sporadic Alzheimer's disease, or late onset, makes up the majority of Alzheimer's diseases. Now here you can see the different risk factors, and remember these are risk factors and not causes. There is a difference, but the biggest risk factor overall when we're looking at both or looking at Alzheimer's altogether are genes and age. So family history as well. Now the major genetic risk factor for late onset Alzheimer's disease is related to apolipoprotein E gene. Specifically though, apolipoprotein E gene allele 4. So we could also state that as being ApoE4. And this is found on chromosome 19. And it's thought to interfere with the amyloid beta clearance from the brain. And it's also processed into the neurotoxic fragments that are found in the plaques and tangles in the brain of people with Alzheimer's disease. You can associate the accumulation of the amyloid beta protein with the formation of the neuritic plaques and tau protein, as mentioned on the previous slide, with the formation of the neurofibrillary tangles. You can also see that there are various other potential risk factors that can increase somebody's likelihood of developing sporadic Alzheimer's disease or late onset. But ultimately what happens, which we've already discussed, is that the breakdown and clearance of the beta amyloid protein changes. And when this starts to accumulate, what we see is this extracellular accumulation of beta amyloid forming these plaques. In addition, we spoke as well about tau protein. You get hyperphosphorylation of tau protein, and it causes tau to build up in a way that's not healthy. And you have these enzymes that act on tau, causing it to misfold. So you get protein misfolding, it starts to clump, and it forms neurofibrillary tangles that are found intracellularly. So once when we have these beta amyloid protein plaques form, it's found extracellularly, and the neurofibrillary tangles from tau protein form intracellularly. And then what this all leads to is changes in the synapse and how it functions, the neural transmission as well, so how the nerve transmits along nerves. There's cholinergic dysfunction. Cholinergic has to do with the release and response to acetylcholine. There'll be loss of the ability to repair and remodel itself from injury. Neurodegeneration is seen, dementia, and then death. And so what we just looked at here was really the two pathways that contribute to the death of the neuron, having to do with tau proteins and the beta amyloid. And most of the neurons that are lost are those that would contain acetylcholine, so a neurotransmitter. And these are found heavily concentrated in areas such as the cerebral cortex and the hippocampus, as mentioned earlier. And these areas are involved in cognitive abilities as well as memory. And so that's why we see deficits in these areas with these patients. Okay, on to a different topic now, in focusing on alterations in cerebral hemodynamics. So pertaining to the heading on the previous slide, what is cerebral hemodynamics? Well, hemodynamics has to do with the circulation of blood, and cerebral is referring to the brain. So we're talking about the physiology or the circulation of the blood within the brain. The next topic to introduce is intracranial pressure. So right now I'm introducing this term here. Intracranial pressure is the pressure inside the skull. So that would be the brain and everything within it, and the blood flow, as well as the cerebral spinal fluid in and around. And that should normally be maintained. So this is normal intracranial pressure between about 1 and 15 millimeters mercury. And our body will constantly adjust for that to keep us within that range. Now, increased intracranial pressure. This can be caused by things such as edema, so really anything that increases the brain volume. Excess cerebral spinal fluid, usually this doesn't happen too frequently. Hemorrhage is another example, so bleeding within the brain. And possibly something that would be considered to take up area of the brain, such as a tumor. So we can say an increase in intracranial contents. And this tumor, when we speak of this, it could be benign and it could also be malignant. In any event, it's taking up space within the skull. Now, because the brain and the associated structures are encased within the skull, any increase in content of any kind within the skull needs an equal decrease in something else. Otherwise, normal blood flow will be disrupted. So it's important to keep us within that 1 to 15 millimeters mercury range. Now, the first fluid to displace when intracranial pressure goes up, just to keep us within this range, is going to be the cerebral spinal fluid. And then if cerebral spinal fluid is not enough, then reduced blood flow will occur and compression of the brain to try to maintain that normal pressure. Now, when there's reduced blood flow and compression of the brain, this is concerning because now we're reducing the amount of blood flow that actually gets to the tissues. And so this could lead to events such as ischemia, so reduced blood flow, but then it could lead to hypoxia. It could end up leading to an infarct to the brain. And so you could probably see why CSF displacement is the number one choice for reducing overall intracranial content to maintain that normal intracranial pressure. There's a term called autoregulation. And autoregulation exists it's a homeostatic mechanism that exists within the tissues and organs and cells within our body, almost like a built-in function. And the brain has this feature as well. And so what autoregulation will allow is for these compensatory alterations in blood flow, for example, or even diameter of intracranial blood vessels to maintain a constant and appropriate flow within the brain and keep pressure normal or within that normal range. And then as intracranial pressure continues to increase, then our body loses its built-in homeostatic mechanism of autoregulation, and it can no longer maintain normal intracranial pressure. And so what happens with this CSF? Well, it ends up being resorbed. And it's the most readily available to displace. We reabsorb it. And in the event that there are small increases in brain volume, and this can happen just from going to a lying down to a seated up position, it doesn't lead to really an immediate increase in intracranial pressure because of this built-in homeostatic mechanism where we displace CSF quite quickly, gets displaced into our spinal canal. But if intracranial pressure still remains high after cerebral spinal fluid is displaced, that's where we get into needing to alter cerebral blood flow, and even compression of the brain is sometimes needed or will occur. Now let's look at the 4 progressive stages now of increased intracranial pressure. In the first stage, and sometimes this increase in intracranial pressure is called intracranial hypertension. So in the first stage of intracranial hypertension, there's a small increase now in intracranial pressure. But it can still be controlled by our body's autoregulation. Now, CSF was already displaced. That wasn't effective on its own. So now what will happen is vasoconstriction and really compression of our venous system in order to further decrease intracranial pressure. So therefore, during the first stages of intracranial hypertension, or first stage, the pressure usually won't change for very long. And so this is because of our effective compensatory mechanisms. And so this is why this stage will oftentimes not present with any detectable changes. In stage 2 of intracranial hypertension, there is a larger increase now in intracranial pressure. And the resulting increase in intracranial pressure can exceed the ability of our brain's compensatory mechanism to adjust for this increase, or maybe it's just enough. So generally, from here to here, we have autoregulation, or our body's compensatory built-in homeostatic mechanism can control for this, but certainly not once we get to stage 3 and 4. And even at stage 2, it can barely be controlled at this point. And so what we see in stage 2 is continued expansion of the intracranial contents, and therefore increase in intracranial pressure. And this will reduce what's called CPP, or cerebral perfusion pressure. Cerebral perfusion pressure is the pressure that's required to perfuse the cells of the cerebrum so that they're getting the oxygen and the nutrients that they need. And so this reduction in CPP will then cause compromise in neuronal oxygenation. So we could say then one of the effects we'll see in stage 2 is neuronal hypoxia. And this is very concerning for brain cells, as you know. And so at this stage, this is where symptoms will start to present themselves: confusion and drowsiness. In stage 3 of intracranial hypertension, this, as already mentioned, is when autoregulation is not enough. As you would expect, now we're seeing diffuse hypoxia and autonomic alterations such as changes in breathing patterns. There's going to be an imbalance between oxygen and carbon dioxide will increase in the blood, leading to what's called hypercapnia and increasing the acidity of the blood too, so acidosis, due to this increase in carbon dioxide. And then stage 4 leads to herniation of brain tissue, and this is where brain tissue will move from the region where it is under higher pressure to an area of lower pressure, so really taking the path of least resistance. And so we'll talk about herniation on an upcoming slide. This chart here summarizes the clinical features of each stage of intracranial hypertension, or increased intracranial pressure. And what you can see is that in stage 1 here, so remember, stage 1 and stage 2 is really when we're in the compensation stages where our brain has that built-in autoregulation that can adjust for some of these changes. But in stage 1, the person would present normal clinically, and we talked about the asymptomatic nature of this stage. The person's awake, they're alert, their pupils are reactive, they're equal and reactive. So each side, if you have a pen light that you shine into the person's pupil, it will react to it, so it will constrict, and this would be done evident equal on both sides. Their breathing is normal. If you remember from normal anatomy, the term eupnea refers to normal breathing. In stage 2, though, subtle changes are noted. The body can still compensate for this increased pressure, though, as we know, but it's kind of getting close to compensation loss. But and so you can see here are some of the changes: confusion, restlessness, and lethargy. But as we progress to stages 3 and 4, the clinical signs become life-threatening should medical intervention not take place. In stage 3, medical intervention may be sufficient for survival with varying outcomes. But in stage 4, interventions are usually futile, meaning that they're really incapable of producing any useful results. And there's that term futile here. So let's look at some of the things that we can see happening. In stage 4, you can see some of the main clinical signs involve pupils not being reactive as they should, so ipsilateral dilation and fixation. So in this case, ipsilateral, so referring to one side. This one pupil is not reacting, it's fixed and dilated. And then as you progress through stage 4, then you have bilateral, so both pupils are fixed and dilated. You can also see changes in breathing patterns. So we have Cheyne-Stokes breathing. This we discussed in normal anatomy. It's a periodic type of abnormal breathing that's seen in terminally ill but also brain damaged patients. And the characteristic of Cheyne-Stokes respiration is this alternating apnea and hyperventilation. So apnea meaning they stop breathing and then they hyperventilate. So it alternates. Apneustic breathing. Apneustic respiration is also an abnormal pattern of breathing, of course, but it's characterized by these deep gasping inspirations. And then these individuals will have a pause at full inspiration, followed by a brief and insufficient release. And then ataxic breathing, and at this point we're approaching death in these individuals. Ataxic breathing is characterized by complete irregularity of breathing. There's irregular pauses, there's increasing periods of apnea. And then the final point to make out here is that the surgical or medical intervention is going to be best before or at the beginning of stage 3, needed certainly in stage 3, and then futile or not producing any useful results, almost pointless once you get to stage 4. This slide discusses brain herniation, which we know occurs during stage 4 of increased intracranial pressure or of intracranial hypertension. And a herniation is defined as a shift in brain tissue. So it's moving from an area of higher pressure to an area of lower pressure. You can see a list of what are really referred to as herniation syndromes or types of herniations from 1 through 6 here. Herniations can occur above or below the tentorial membrane. And the tentorial membrane is really an extension of the dura mater of the brain, and it separates the cerebellum here from the inferior portion of the occipital lobe of the brain. And so we can have supratentorial herniations or infratentorial herniations, so either above or below. And 1 through 4 here are all showing you supratentorial herniations, and 5 and 6 are representing infratentorial herniations. But the most common herniation syndrome is a type of infratentorial herniation that's not explicitly shown in this image, and this is referred to as cerebellar tonsillar. And in this case, the cerebellar tonsils shift through the foramen magnum because of increased pressure. So here's your foramen magnum, and this is where the spinal cord, or what we could say the extension of the end part of the brainstem or the medulla oblongata, is going to exit the skull. And then we have the spinal cord that would run down the spine. And so because this is a large opening, the movement of the cerebellum inferiorly can occur. And so this is the most common, and it is considered fatal when this happens. And one of the reasons it can become fatal is because the cerebellum, when it herniates, is going to put pressure onto the brainstem. So it causes brainstem compression. And this can lead to different respiratory abnormalities, including Cheyne-Stokes breathing, which we spoke about earlier, as well as pulse variations because of the involvement in the brainstem in these functions. It's also interesting to note that the herniating tissue, wherever it is, so in any of these examples here, the herniating tissue now is going to cause an increase in intracranial pressure in the area that it is herniated into. So in the case of this part of the brain herniated over here, well, it's reduced the pressure in this area by moving into this direction, but now it's increased the pressure in this region here. Now, the exception would be if there's a crack in the skull where part of brain tissue can actually herniate outwards. But in any other example, it's going to be increasing pressure in the area that it herniates into. And so the herniating tissue's blood supply is going to be compromised, and it's going to cause ischemia and hypoxia to that herniated tissue, which can lead to an infarct. So let's talk now about cerebral edema. And cerebral edema in itself, even though we're talking about it as a separate concept as increased intracranial pressure, it in itself can lead to increases in intracranial pressure, but not necessarily. Cerebral edema can be a condition on its own. Cerebral edema is an increase in fluid content of brain tissue, and of course, if it's not adjusted for, then that's where it increases pressure in a concerning way. Now, this increase in fluid can either be extracellular or intracellular. In terms of when it can occur, well, it can occur if there's some sort of brain insult, so let's say some brain trauma. If there's an infection, it can lead to cerebral edema. If someone suffers from an infarct, some of the pathways that occur can lead to edema. Somebody has a hemorrhage within their brain, it can also lead to cerebral edema. Now, there are three types of cerebral edema: vasogenic, cytotoxic or metabolic, and interstitial. Vasogenic edema. This is clinically the most important type, and it's caused by the increased permeability of the capillary endothelium of the brain after some injury to the vascular structure. So what that means really is that there's an increased permeability of the blood-brain barrier. So the blood-brain barrier becomes disrupted. And what will then happen is plasma proteins that normally exist within the vessels are going to leak out because of this vascular damage into the extracellular spaces. And when these proteins leak out, they're going to draw water with them. And this is going to overall increase water content of the brain's parenchyma. Vasogenic edema will then begin in whatever area is injured, and then it can spread and cause increasing amount of fluid within that area, which disrupts for instance, the axons that are found within the brain. And this type of edema is usually more frequently seen within the white matter of the brain, and so affecting a lot of the axon tracts. With cytotoxic or metabolic edema, toxic factors are going to directly affect the cellular elements of the brain. So we're talking about the neurons and the glials. And what it will end up leading to is the failure of active transport mechanisms. And so cells will end up losing potassium, and then they'll gain larger amounts of sodium, and then water follows by osmosis into the cells, and this will cause the cells to swell. And cytotoxic edema occurs principally in gray matter, whereas we spoke about vasogenic occurring in white matter of the brain. And finally, Interstitial edema is most often seen with what we'll talk about on an upcoming slide, which is hydrocephalus, more specifically non-communicating hydrocephalus. The edema is caused by the movement of cerebral spinal fluid from the ventricles into the extracellular spaces of the brain tissues. And this will cause brain fluid volume then to increase substantially. And this also will affect the white matter of the brain, just like vasogenic edema will. Now let's speak about hydrocephalus in a little bit more detail. It's defined as excess fluid or excess cerebral spinal fluid within the brain's ventricular system. And there's a few different potential causes. One of them is increased CSF production. This is rare. But what's more common is some sort of obstruction where maybe there's, for instance, a tumor, for example, that disrupts the flow of CSF through the subarachnoid space. Another cause is defective CSF resorption. Remember that the CSF will circulate and then be reabsorbed, and this is a continual process. There are two types that exist, communicating and non-communicating hydrocephalus. Communicating hydrocephalus results from impaired reabsorption of the cerebrospinal fluid in the absence of obstruction. Okay, so when we talk about communicating, we're talking about impaired reabsorption in the absence of a true obstruction. And so when we talk about obstruction, we mean between the ventricles and the subarachnoid space. But it's instead inflammation that causes this type of hydrocephalus. And so a good example, as we've already spoken about, is inflammation of the meninges or meningitis. And so sometimes communicating hydrocephalus is also called non-obstructive hydrocephalus, and this one is more commonly seen in adults compared to children. Non-communicating hydrocephalus. This is also called obstructive hydrocephalus, and it's caused, as you would expect, by some sort of obstruction within the ventricular system, as I mentioned earlier, and an example could be a tumor. So this tumor is obstructing the normal flow of CSF, and the fluid can't reach the convex portion of the cerebrum where those arachnoid granulations are found, which are responsible for reabsorbing the cerebral spinal fluid. So if it can't get there, and it can't be reabsorbed, but yet you're still producing cerebral spinal fluid, then it can lead to hydrocephalus. And this is the one that's more commonly seen in children. Now, children have an advantage, I should say infants and very young children, in that their skull bones have not fused together and they have fontanelles present in various areas of their skull. And this allows for expansion. So whereas with a child that has had all of their fontanelles close over, all their sutures are fused, then there's no room for this excess fluid to go. But with children, there is that ability to expand because of the presence of these fontanelles, and so it's less likely to be compressing the brain compared to someone who didn't have fontanelles. Now we're going to move on to talking about alterations in neuromotor function. So we're taking a bit of a different turn now, talking about Parkinson's disease. Parkinson's disease involves the loss of the dopaminergic neurons within the brain, and loss of these neurons, which produce dopamine, leads then to a dopamine deficiency within the basal ganglia of the brain. Now, in the brain, dopamine functions as a neurotransmitter, so a chemical released by neurons to send signals to other nerve cells. And this deficiency can lead to what's referred to as Parkinsonism. And Parkinsonism is any condition that causes a combination of movement abnormalities that are seen with Parkinson's disease. And so this usually includes tremors, slow movement, rigidity, akinesia. Akinesia is defined as a decrease in voluntary and associated movements of the body. And there are two types, primary and secondary Parkinson's disease. And primary is more common in men after the age of 40. Secondary has different causes. Somebody who was a boxer for many years, had multiple head traumas, could suffer from Parkinson's like disease. Individuals that have encephalitis or inflammation of the brain could also suffer from this. And those with primary tumors of the brain affecting certain areas of the brain can also present with Parkinsonism. It is specifically the substantia nigra that will look like these dark dots in the image, and that's because they're made of melanin, and they're used to make the neurotransmitter dopamine, so they're affected then in those with Parkinson's disease. And so you can see the difference here between the normal substantia nigra and then those with loss of the substantia nigra, and therefore leading to a deficiency in dopamine. Now let's have a look at the pathophysiology of Parkinson's disease. In terms of cause, we can look at the possibility of oxidative stress within the brain, mitochondrial dysfunction, as well as loss of nerve growth factors. And we can also look at genetic predisposition as putting someone at risk for the development of Parkinson's disease. Now let's look at genetic predisposition first. Accumulation of a protein called alpha-synuclein can occur. And the protein can misfold and really render itself non-functional. Now, with accumulation of this protein, we form what are called Lewy bodies. And these are concentrated within the regions of the basal ganglia, and this ends up leading to degeneration of these dopamine-containing neurons that arise from the substantia nigra, as we spoke about in the previous slide. So we can call that neurodegeneration because there's degeneration of these particular neurons. And we know then that this leads to a deficiency in dopamine production. Or, of course, with oxidative stress, mitochondrial dysfunction, and loss of nerve growth factors, it can lead to the same events of neurodegeneration within the basal ganglia, leading to that deficiency in dopamine. And this will cause loss of that normal inhibition of muscle tone, which can lead to tremors, rigidity, as spoken about on the previous slide. We spoke about akinesia, but bradykinesia is the slowness of voluntary movements. So in this case, all voluntary movements become slow and labored, more difficult. And both bradykinesia and akinesia, they involve delay in the time it takes to start or to perform a particular movement. Now let's speak for just a moment about the relationship between acetylcholine and dopamine in normal individuals. Remember that acetylcholine is also a neurotransmitter. Think of acetylcholine and dopamine as really antagonistic, because we have acetylcholine as being really an excitatory neurotransmitter, whereas dopamine is the inhibitory neurotransmitter. And so you can think of almost like driving a car. You have an accelerator pedal and a brake pedal. And between the two, you can regulate the speed of the car. So what happens in the case of Parkinson's disease is you have this imbalance between the accelerator and the brake, or the acetylcholine and the dopamine. And so this imbalance is going to lead to uncoordinated movement. Whereas when they're in balance, both acetylcholine and dopamine, then you have nice controlled movement. And so with this dopamine deficiency, once again, we lose that normal inhibition of muscle tone. And then now we have the acetylcholine activity that promotes muscle tone, which further increases the resting tremors and the rigidity and so on and so forth that we will see in this condition. And this image here demonstrates what I just spoke of, that in normal individuals, you should have that nice balance between dopamine and acetylcholine. But with Parkinson's disease, we have that imbalance where we lead to a disturbed, uncontrolled, or uncoordinated movement. Now we'll move on to talking about upper and lower motor neuron syndromes. Motor function alterations can be classified according to the severity of the alteration as well as the area that's affected. The term paresis refers to partial paralysis, really muscular weakness. Whereas paralysis, sometimes referred to as plegia, is complete loss of motor function. And you can see that in terms of areas affected here, hemi is referring to extremities on one side of the body, but para and quadriparesis or plegia will affect either the lower extremities, in the case of paraparesis, or the lower and the upper extremities in the case of quadriparesis. And you would have most likely have heard of it as referred to as paraplegia, where somebody has function of the upper extremities but not the lower extremities, and quadriplegia where they have both upper and lower extremities affected. Another important question to ask, though, when it comes to motor function alterations is whether or not the injury affected an upper or a lower motor neuron. And so we'll take a moment to have a look at that now. When we move a muscle, we need two neurons. We need from the brain to the spinal cord. So here we have from the brain to the spinal cord, and this is referring to an upper motor neuron. And then we have from the spinal cord to the muscle that it innervates, which would create a movement once it gets that signal. And this would be the lower motor neuron. And notice that we're referring to motor in each case, so in each case rather than a sensory neuron. And that is really all I want you to be aware of from this slide here, is that we have the upper motor neuron and the lower motor neuron. And depending on the person's particular injury, whether it's an upper motor neuron injury or a lower motor neuron injury, will change the nature of the effects of that injury. So disturbances in motor function then can be classified pathologically along an upper and or lower motor neuron structure. Remember, upper motor neuron affecting spinal cord, brain to spinal cord, lower motor neuron affecting really the muscles or nerves outside of the central nervous system. But with a lower motor neuron injury, what you'll more frequently see would be flaccid muscles. The muscles are very weak. They don't show much tone, hypotonic, and hyporeflexive, meaning that these individuals will present with underactive or under-responsive reflexes when they're tested with, let's say, a reflex hammer. But in the case of an upper motor neuron lesion or injury, it'll be quite the opposite. Spastic muscles, where they're remaining in an overcontracted state, can lead to stiffness. The muscles have more tone than they should, hypertonic, and hyperreflexive just means that they have overactive or over-responsive reflexes. And you can see that there's a few items that have been highlighted here, which we'll be reviewing many of these in this course and in this lecture. Trauma, vascular lesions, demyelinating diseases such as multiple sclerosis, which we'll talk about today as well, and we've already spoken about Parkinson's disease, so upper motor neuron lesions. Whereas with the lower motor neuron lesions, an example that I will give you here would be myasthenia gravis, which we will not be talking about in this lecture, as well as amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease. Let's begin by talking about traumatic brain injuries as well as spinal cord injuries, so injuries to the central nervous system. Let's start with traumatic brain injuries. There are two types, primary and secondary traumatic brain injury. We can loosely define traumatic brain injury as an alteration in brain function that's caused by some sort of external force. The primary injury is the direct impact or the direct injury, whereas the secondary is really the consequence of the primary injury, so what we consider all the secondary effects that occur after and is therefore considered indirect. And if you look down at this image, you can see the differences between the primary injury and the secondary injury. So the primary being what actually happens. So somebody had a skull fracture or a contusion. We'll talk a little bit about this, maybe a concussion. And then the secondary is everything that happens after that. And it can be something not so severe to actual death of brain tissue, depending on the circumstance. So some important terms to go over with you now include closed versus open trauma. Closed traumas are more common and they involve either the head striking a hard surface or some rapidly moving object striking the head. And what this will do is injure the brain, but the skull and even the dura mater will remain intact. So the brain tissues are not exposed to the environment. Now, this can lead to a high risk of cerebral edema. So if there's bleeding within the brain, but there's no break in the skull, then you're going to end up with an increase in intracranial pressure. Most closed traumas that exist, or most blunt traumas, are considered mild in terms of the majority of these injuries. Open traumas, though, also called penetrating, this occurs when there is a break or penetration of the skull and the dura mater, and it results in the exposure of cranial contents to the environment. The terms contusion and concussion should not be used interchangeably. A contusion you can think of as being a bruise to the brain or a brain bruise where blood leaks out from an injured vessel and can vary in terms of severity. But a concussion is a type of brain injury where there's not really substantial, if at all, structural changes that are evident, and it's more of a functional issue rather than a structural one. There's also coup or contra-coup brain injuries that exist, and we'll look at an image of this on the next slide. But a coup injury is the injury to the direct area that was impacted by a fall, for example, where somebody hits the front of their head and there's injury to, let's say, the frontal lobe of the brain. But a contra-coup injury is injury on the opposite side of impact. So if you hit, for example, the front of your head and you injure the front of your brain, then the brain can move around and hit the back of the skull, so the opposite area of impact, and that's called a contra-coup brain injury. Different types of brain injuries exist as well. We have our different types of bleeds. We have epidural hematomas, subdural hematomas, intracerebral hemorrhaging, and subarachnoid hemorrhaging. And we'll have a look on an upcoming slide what's involved in those different injuries. In this image here, you can see what a contusion would look like on the brain, so that bruising I spoke of earlier, and then this image demonstrating the coup and contra-coup injury. So in this individual, if they've hit their head here, so this temporal lobe of the brain will be affected, and with a contra-coup injury, well, so will the opposite temporal lobe as well. And so this is actually more frequently seen, a coup contra-coup injury, when the temporal lobe is hit, and then the opposite temporal lobe is affected as well. In addition, if somebody hits the back of their head, so an injury to the suboccipital or to the occipital region of the skull, this will affect the occipital part of the brain, so at the back of the head, and oftentimes will also affect the frontal lobe. And so this is where you have another example of a coup contra-coup injury, hitting the back of the head first, and then the brain hitting the front of the head. And the opposite isn't necessarily true. When people hit the front of their head, it doesn't usually impact the occipital lobe as well. But when someone hits the back of their head, it will more frequently affect the front of the brain. And that's just because of the different design of our skull in terms of what areas of the skull are smooth versus more rigid. Here are some examples of the different types of bleeding that can occur within the cranium. And we mentioned these particular terms on a previous slide, so we're going to go through each one of them and give you just a little bit of information. At the top, epidural hematoma. This is bleeding between the dura mater and the skull. If you remember the details about epidural, epi is above the dura, but beneath the skull. And in this case, most oftentimes it's an artery that's a source of the bleeding. And so because it's an artery, the blood can accumulate quite quickly. Subdural, on the right, these are characterized by bleeding between the dura mater and the arachnoid membrane, so subdural meaning beneath the dura. Most of them are associated with falls, so they can be seen and sometimes referred to as chronic subdural hematomas in the elderly or in those that abuse alcohol. And so over a relatively short period of time, they can have blood accumulate. And so what could happen is, let's say you have an individual that had a bad fall, they hit their head, and they present to the doctor. Everything seems to be fine, but they could have a slow bleed over a short period of time. And so these individuals will need to present back to the hospital or to their family doctor for another checkup to make sure that there isn't a bleed that needs to be addressed. And the reason that this is slower in terms of the accumulation of blood is because it usually impacts the veins rather than the arteries, as with an epidural hematoma. Okay, intracranial hematomas, this type of bleed occurs into the cerebrum, so intracerebral, so within the cerebrum. And as you can see, with the accumulation of this blood, it's causing shift in brain tissue, so quite an increase in pressure within the cerebrum. And then subarachnoid, the final example, this is hemorrhaging in the subarachnoid space. Remember, that's where cerebrospinal fluid circulates. And in these individuals, aneurysms are quite commonly the cause of subarachnoid hemorrhages. So let's talk a little bit about infection and inflammation of the central nervous system. We've already spoken about meningitis, but we're going to talk about encephalitis. Encephalitis is defined as diffuse inflammation of the brain, and anytime you see the term itis, it's referring, remember, to inflammation. Usually it's viral in origin. Now, in those who are immunocompetent, meaning that their immune system is intact, the most common causes are herpes encephalitis, and this causes inflammation of the brain. And in these individuals, they will oftentimes have psychotic episodes that just come out of nowhere, but it usually responds to antiviral drug therapy. Dengue encephalitis, or dengue fever found in tropical countries, presents really like a bad flu. West Nile encephalitis, this is something that's even seen here, so it's an important consideration. But in those who are immunodeficient, so their immune system is not intact as it should be, viruses such as measles, mumps, and rubella can be a problem, and parasites such as toxoplasmosis, or what would cause toxoplasmosis, and malaria can lead to inflammation of the brain. And from this image here, what I want you to take from it is that the biggest target of viruses, again, because that's the most common origin of encephalitis, are the neurons. And so you can see quite a list of different viruses here impacting the neurons. So it could be the supporting cells as well, such as the oligodendrocytes, microglia, but the neurons are the greatest target. This slide demonstrates the hematogenous spread of a viral pathogen to the central nervous system. So first of all, we have entry into the host. Then it's going to replicate in a particular area depending on where it actually entered the host. Then the virus will replicate in other areas known as secondary replication, so traveling to other areas and replicating. And this leads to persistent viremia, meaning that the virus is present in the blood and persists there. And when this happens, now it has the ability to work its way to the brain and cross the blood-brain barrier. And at this point, it can infect the cerebrospinal fluid, but it can also infect the vascular endothelium, so the vessels themselves, leading to inflammation, and the source being a virus. Now we're going to move on to demyelinating disorders. and we're going to talk about multiple sclerosis. MS is fairly common in the Northern Hemisphere, and so it's an important condition to discuss. It's known as a demyelinating disorder of the brain, and what that means is there's progressive loss of myelin. Myelin, if you remember, is a supporting cell of the central nervous system and the peripheral nervous system. Remember, it takes on different names, so it's called the oligodendrocytes within the central nervous system and Schwann cells within the peripheral nervous system. And myelin allows for the transmission of electrical impulses. So it's a supporting cell, it's protective, but it allows for fast electrical impulses. And so in these individuals that lose myelin, they end up with reduction in electrical impulses, which affects many different functions, including motor control. Cause, not a whole lot's known about it. It is more common in women, especially between the ages of 20 and 40, but it is known to be an autoimmune disease where the body is attacking its own myelin, causing destruction. And so what you can see happening is this axon, which was once covered and protected by myelin, is now exposed. And when it becomes exposed, then the axons themselves can become damaged. Multiple sclerosis gets its name from, one, the term multiple, because it tends to affect multiple areas. And so there's these what are called MS lesions that are found in many different areas within the brain. And sclerosis comes from the fact that once the myelin has worn away, then the axon, as I mentioned, is exposed and can become damaged. And when it becomes damaged, because it's not protected, it degenerates and it starts to form scars, or what are referred to as sclerotic lesions. And both the motor as well as the sensory pathways can be affected with multiple sclerosis, but the actual deficiencies are going to depend on the particular location of the lesions. And when myelin is lost, the ability to have an action potential, move properly along an axon, especially one that is sclerotic, will be diminished or even lost. And once again, this is progressive, so especially if it's not treated, will worsen and can worsen quite quickly. But these individuals will go through stages of remission and exacerbation. Okay, now we'll talk about tumors of the central nervous system. So what are the major tumor types of the central nervous system? Well, there are three major types: primary intracerebral, so intracerebral, primary extracerebral, and metastatic brain tumors. The primary tumors of these, the most common are gliomas. And gliomas make up about 50 to 60% of adult brain tumors. A glioma is a type of tumor that will start in the brain or the spine, so within the central nervous system, and it's called a glioma because it arises from glial cells. And remember, glial cells are these supporting cells of our central nervous system. So glial cells are different than neurons. And the most common site of gliomas is actually within the brain. Some examples of glial cells that tumors could arise from could be oligodendrocytes, Schwann cells, astrocytes, microglia, satellite cells, for example. And some of these can be benign, and sometimes they can be malignant. But remember that if you have a tumor within the brain that's increasing in size, it's going to cause an increase in intracranial pressure and put pressure on other structures and even possibly lead to brain herniation and tissue death, etc. An extracerebral tumor example that I've given you here is a meningioma. So oma referring to tumor. This is a tumor of the meninges. And so this is an example here. And because of the superficial nature, and remember it's extracerebral, so outside the cerebrum, this is something that could be removed a lot easier than one that's found within. So in this example of a glioma here, this is concerning, and this is less concerning. And then finally, metastatic brain tumors. So for example, lung, breast, or in this case, melanoma, so someone that had skin cancer that spread to the brain. Quite a scary thought. Because remember, when we talk about metastatic brain tumor, we're talking about cancer that was present elsewhere in the body that has spread to the brain. And the lung is a very common, lung cancer can spread to the brain. This is just another image showing you what we discussed on the last slide, the different types of tumors. The gliomas here represented in red, glioblastoma multiforme, oligodendroglioma, and frontal astrocytoma, examples of primary brain tumors. Remember, these are intracerebral. The primary extracerebral, we have a meningioma as an example, and pituitary adenoma, and these are usually benign. And then, of course, metastatic tumor, in this case, that has spread from the lung, but really any organ that is infected with cancer could spread to the brain. Let's look for a moment at tumors in children. What I would like to point out to you is that the most common tumors seen in children are medulloblastomas and cerebral astrocytomas. The other one I want to point out are retinoblastomas. You can note here that the medulloblastomas and cerebellar astrocytomas are infratentorial tumors, so affecting or arising from the brainstem as well as the cerebellum. Actually, I'll correct myself just to say that both of these originate from the cerebellum, where there are specific tumors that arise in the brainstem. But with medulloblastomas, they're interesting because they can actually invade into the cerebral spinal fluid. And then the last thing I wanted to mention are retinoblastomas here. These, you can see how it presents in a child. And there is an important genetic component to the development of retinoblastoma. And let's finish up by looking at the clinical manifestations of an intracranial neoplasm. How do you know clinically that a person may have a tumor? Well, there are some signs and symptoms that can be present, and they are due to the increase in intracranial pressure that neoplasm can cause. And the signs and symptoms that you can see listed here are self-explanatory. We've talked also about papilledema before, which is optic disc swelling that can happen because of increased intracranial pressure. But a neoplasm can also lead to invasion and compression, and where it invades can cause some focal deficits, but that invasion itself can also lead to cerebral edema, which brings us back again to the increased intracranial pressure. And then, of course, compression by that neoplasm can cause the same effects with edema, leading to increased intracranial pressure. And of interesting note, and there's still a fair amount of uncertainty as to why this is, but malignant intracranial tumors do not metastasize to other areas of the body, whereas we know that malignant tumors throughout the body, whether it's skin cancer or breast cancer or lung cancer, we know that it can metastasize to other areas of the body, but intracranial malignant tumors do not metastasize. The spinal cord can also be injured, and two of the frequent mechanisms of injury include hyperextension and hyperflexion injuries, most commonly of the neck. And what this can lead to is the fracturing of the vertebrae and or herniated intervertebral discs. So let's have a quick look at the normal anatomy. If this is showing you the vertebrae, and this is actually part of it as well, the spinous processes. And then in between, we have the intervertebral discs that are really the shock absorbers of our spine. And then running through here would be our spinal cord. And in the case of a herniated intervertebral disc, so we're looking here at an hyperextension injury, is that the intervertebral disc can herniate from where it's supposed to be. And you can see in this image that now it's compressing the spinal cord. And this is a better image to demonstrate that if we look as a more of a superior view of the vertebrae, is that the intervertebral disc would lie here, and on the outskirts we have what's called the annulus fibrosus, and then on the inside we have the nucleus pulposus. And with certain injuries, such as hyperextension in this case, the nucleus pulposus can migrate out of where it should be. And depending on where it migrates out, it can put pressure on the spinal nerve, sometimes just the spinal nerve. And in more serious cases, when you have very much a posterior herniation, it can compress the spinal cord itself. And you can see how the spinal cord has deviated now from its central location. So this can be very, very concerning, and this type of herniation needs to be addressed medically immediately. Vertebral fractures, on the other hand, here's an example of, let's say something large was dropped on this person's head. It can cause compression of the vertebrae, and when the vertebrae compresses, it can actually fracture, as you can see here. And what this can do is it can cause displacement of the fractured segments, potentially to the spinal cord, injuring the spinal cord itself, but it can also protrude because it's been squished or flattened, and you can see that protrusion is now compressing the spinal cord. That's the end of today's lecture. Thank you for listening.